Medical School for arranging a nice class on different aspects of hypertension and management of hypertension regarding case-based and evidence-based. And today we will discuss on hypertensive emergency. That's an important chapter. Along with hypertensive emergency, we will discuss hypertensive urgencies as well as malignant hypertension. So thanks again for giving me opportunity to discuss on hypertension. This is the third class, I think, and this class is on hypertensive emergency. So we'll discuss a case at first, and then we'll see how this patient should be managed according to the evidence-based, what the evidence says, what the study says. So we'll talk on management of hypertensive emergency and hypertensive emergency according to the guidelines says. So this case is about how will you manage a case of 45 years old gentleman presented with headache and visual disturbance and papilledema with blood pressure 200/115 millimeter mercury, admitted in ICU department. So what are the information we can get from this case scenario? This is a gentleman, 45 years old. There is a young patient, there is a middle-aged patient who had complaints is headache and visual disturbance and papilledema. So physical findings and the complaints are headache and visual disturbance. So we all know that headache is a symptoms of hypertension, and as the patient has got visual disturbance and papilledema, so there is a involvement of the retina or involvement of the eyes involvement, and as there is a visual disturbance and papilledema. So what information we can get here that this patient had definitely have hypertensive retinopathy. So there is a target organ damage, and I have already discussed in previous two lectures that what are the target organ of hypertension. So target organ as brain, retina, eyes, that is heart, kidneys, and peripheral vessels. These are the target organ of hypertension. And as hypertension is not controlled enough, so there may be damage of this target organ may occur. And as there is a target organ damage and patient blood pressure is about 200/115 millimeter mercury. So according to the classification JNC6 or JNC7 classification, or according to the European Society of Cardiology classification or American College of Cardiology classification, this patient is in the group of malignant hypertension or stage 3 hypertension or grade 3 hypertension. So stage 3 hypertension, as the patient has got stage 3 hypertension or grade 3 hypertension along with target organ damage like visual disturbance and papilledema. So this patient actually labeled as hypertensive emergency. So what are the features of hypertensive emergency? If we discuss about the features of hypertensive emergency, the hypertensive emergencies are patient is in stage 3 or malignant hypertension or grade 3 hypertension. Along with grade 3 or stage 3 hypertension, patient should have any target organ, features of any target organ damage, like patient may have hypertensive features of hypertensive encephalopathy, patient may have a stroke, patient may have transient ischemic attack, or patient may have involvement of the heart in the forms of heart failure or ischemic heart disease, or in the form of acute coronary syndrome, or there may be hypertrophy of the heart. So there may be cardiac involvement, or there may be renal involvement in the form of chronic kidney disease, or in the form of diabetic, hypertensive microalbuminuria, hypertensive albuminuria, or in the form of CKD, chronic kidney disease, or raised serum creatinine level, or raised blood urea nitrogen.
Sir, আপনার স্লাইডটা চেঞ্জ হচ্ছে না এখানে।
না স্যার, আমি এখনো দেইনি স্লাইড, মানে আগাই নাই, ঠিক আছে? ঠিক আছে, আমি এই স্লাইড ধরে একটু আলাপ করে নিচ্ছি, নেক্সট ইয়ে করবো নি, ঠিক আছে?
আচ্ছা
আচ্ছা,
ওকে
ঠিক আছে, গুড। ঠিক আছে, এই নেক্সট স্লাইড ইয়ে করে দিই তোমার। হ্যাঁ, আচ্ছা, so there is a target organ damage, and this target organ damage, the damage may occur in any target organ. We have discussed maybe brain involvement, maybe heart involvement, maybe eye involvement in the form of hypertensive retinopathy. Patient may have papilledema, or maybe any grading of hypertensive retinopathy, or there may be involvement of the peripheral arterial atherosclerosis, like atherosclerosis in the lower limb, atherosclerosis in the upper limb, or there may be carotid media, intima media thickness increased, or there may be renal artery involvement, or atherosclerosis in the any part of the body is blood vessel. So there may be features of target organ damage. And as the patient has got target organ damage along with grade 3 hypertension, so this patient should be managed in the CCU or in the ICU setting. So this patient should be admitted into the hospital and should be transferred to the ICU or CCU for proper management as well as proper monitoring of the patient, as this blood pressure of this patient should be lowered down as early as possible. Because if we do not lower down the blood pressure, in that cases, other organ may be involved, or other organ damage may ensue, or other maybe involvement of the other organs also. So to reduce the target organ damage, we have to admit the patient in the ICU or CCU, and we have to lower down the blood pressure to the normal level as early as possible. And how we actually lower down the blood pressure of this patient, as we have to lower the blood pressure rapidly, so we have to use intravenous antihypertensive like intravenous labetalol, or intravenous actually sodium nitroprusside, or IV nitrates maybe we can use to reduce the blood pressure to the normal level as early as possible. So this is the way how actually we manage a case of hypertensive emergency or a patient with malignant hypertension. So hypertensive emergency is a very important emergency. This is the medical emergency. So when we see a patient with hypertension with grade 3 or stage 3, and the patient has got features, any features of target organ damage, and this patient actually should be admitted into the CCU or ICU and should be managed and monitoring there, and this blood pressure should be lowered down, or blood pressure should be reduced by IV antihypertensive. So actually this is the main features of a patient with hypertensive emergency, and how actually we manage a patient with hypertensive emergency. So this is the another term that is called hypertensive urgency. So we'll see what is the difference between hypertensive urgency and hypertensive emergency. We'll also see the differences. Now we'll talk on hypertensive urgency. So what is hypertensive urgency? In hypertensive urgency, actually we see that there is a stage 3 or grade 3 hypertension. That is, patient has got malignant type of hypertension, but in case of hypertensive urgency, there is no target organ damage. So in case of hypertensive urgency, actually we see the patient that there is a rapid rise of blood pressure due to any other cause, that is maybe due to usually due to anxiety or stress, or due to actually some other causes that causes the rapid rise of blood pressure. And usually in these cases, a patient with hypertensive urgency, actually there is no target organ damage. As there is no target organ damage, so in that cases, actually we don't admit this patient to the hospital. Actually, among this patient usually don't need to get admitted into the CCU or ICU, and this patient, we can serve this patient, or we can manage this patient as an outpatient basis. So this patient may be treated as outpatient department patient, or this patient may be treated even in home management. So how this patient actually blood pressure should be lowered down? In that cases, we actually don't hurry to lower the blood pressure. In that cases, we can lower the blood pressure gradually, and usually we use to lower the blood pressure actually the oral antihypertensive medications. So we use oral antihypertensive medications to lower the blood pressure in case of hypertension, hypertensive urgency or hypertensive urgency. So now we'll see what is the difference between hypertensive urgency and hypertensive emergency. So what are the similarities and what are the differences? The similarities are, in case of hypertensive emergency, the blood pressure is usually in the stage 3 or grade 3 hypertension, and in case of hypertensive urgency, the blood pressure is also very raised, that is malignant hypertension, that is patient is in grade 3 or grade or stage 3 hypertension. So this is the similarity. So what are the differences between the urgency and emergency? The differences is between that in case of hypertensive emergency, there is usually features of target organ damage. But in case of hypertensive urgency, there is no features of target organ damage. But and the other differences are, usually we treat a patient with hypertensive emergency in the CSU or ICU setting, and in case of a patient with hypertensive urgency, we usually treat the patient as an outpatient basis. And the other differences are, to reduce the blood pressure in a patient with hypertensive emergency, usually we use intravenous antihypertensives. But in case of to lower down the blood pressure, in case of hypertensive urgency, we usually use oral antihypertensive drugs. So this is the difference. Actually, and to lower down the blood pressure in case of hypertensive urgency, usually we are hurry. We need rapid reduction of the blood pressure. But in case of hypertensive urgency, actually we don't need to lower down the blood pressure rapidly. We may slowly lower down the blood pressure. So actually this is the difference between hypertensive urgency and hypertensive emergency. So emergency is emergency and urgency is urgency. So we have to be careful to diagnose a patient with hypertensive emergency or hypertensive urgency. So we have to sure that whether the patient is in hypertensive emergency or hypertensive urgency. So we have to meticulously look down that a patient has got any target organ damage or not. So the differences, so how will actually the main point, how we can differ from a hypertensive urgency and hypertensive emergency. The most important point is that there is target organ damage. If there is target organ damage, that is hypertensive emergency. If there is no target organ damage, that is hypertensive urgency. So hypertensive, the target organ damage, features of target organ damage is very much important to diagnosis either hypertensive urgency or hypertensive emergency. So it is very much necessary to diagnose the features of the target organ damage. So at first, we have to have knowledge that what are the target organ damage, and we have also to have a knowledge that what are the features of target organ damage, what are the features of brain involvement, what are the features of eye involvement, what are the features of cardiac involvement, and what are the features of renal involvement, and what are the features of peripheral vessels involvement. So this is very much important. So we have to have knowledge as well as we have to have a skill to diagnose the different features of a patient with target organ damage of hypertension actually. So this is the very, very much important to otherwise, if we don't fix the diagnosis of hypertensive urgency or emergency, so the management will be very much variable or management will not be accurate. So this is the a flow chart that describes the management of a patient with hypertensive emergency, that is hypertensive crisis. So we'll cause hypertensive emergency or hypertensive crisis, or hypertensive crisis include actually both hypertensive emergency and hypertensive emergency. So when a patient came with systolic blood pressure more than 180 millimeter mercury and or diastolic blood pressure more than 120 millimeter mercury, that is a hypertensive crisis. And then what actually we emphasize to diagnosis or to differentiate urgency and emergency. So we have to diagnose or we have to see if there is any target organ damage or not. There may be a target organ new features of target organ damage, or there may be progressive features of target organ damage, or there may be worsening features of target organ damage. So if there is a target organ damage, that may be new, that may be progressive, or that may be worsening. So if anyone is present, it is called hypertensive emergency, and this patient should be admitted to the ICU or CCU to manage and also to monitor the patient. And if there is other features along with hypertensive emergency, like aortic dissection, like severe preeclampsia or eclampsia, or pheochromocytoma crisis, if these features are present with hypertensive emergency, then actually we reduce the systolic blood pressure to less than 140 millimeter mercury during the first hour. So it is very much necessary to lower down the blood pressure. That is a large amount of blood pressure, or a large amount of rise of blood pressure should be lowered down to less than 120 millimeter mercury may be needed. And in case of aortic dissection and severe preeclampsia or eclampsia. And if these three features, that is aortic dissection, severe preeclampsia or eclampsia, and pheochromocytoma crisis are not present along with hypertensive emergency, in that cases, how we reduce the blood pressure? We reduce the blood pressure by maximum 25% over 1 hour, first hour, and then to 160 by 100 or 110 millimeter mercury over the next 2 to 6 hours, and then to normal over next 24 to 48 hours. That is, if as there is no aortic dissection, no eclampsia or pheochromocytoma, in that cases, actually, we usually we may have actually more time to reduce the blood pressure, and we can slowly lower down the blood pressure relatively than if a patient has got hypertensive emergency along with some features like aortic dissection and severe eclampsia and pheochromocytoma. In those cases, we have to lower down the blood pressure very rapidly, actually. And if there is no target organ damage, in that cases, we label the patient as hypertensive urgency. In that cases, actually, we intensify oral antihypertensive drug therapy, and actually we arrange follow-up as an outdoor basis. So this is the flow chart, how we manage a patient with hypertensive crisis. That may include hypertensive emergency and hypertensive urgency. And if the patient is hypertensive emergency, actually we lower down the blood pressure a little bit rapidly. And if there is a hypertensive urgency, we actually lower down the blood pressure a little bit slowly, and in the outdoor basis, or even in the home management can be done. And this is the work of actually to diagnose a patient of hypertensive emergency. Actually, what are the investigations and what are the physical findings usually we want to find out, or we want to see, or we have to see actually in a patient with hypertensive emergency. Fundoscopy is a must, because by fundoscopy, actually we diagnose if a patient has got any hypertensive retinopathy or not. Tubeless ECG it will be ECG actually, why it is necessary. By 12-bit ECG, we can diagnose if there is a hypertrophic cardiomyopathy, there is a concentric LV hypertrophy or hypertrophy, features of hypertrophy is present or not, that is LVAs, or we can diagnose if a patient has got acute coronary syndrome or not. Even a patient with ischemic heart disease or a patient with acute coronary syndrome, there may be features in the 12-bit ECG we can get. There may be hemoglobin plotted count and fibrinogen. Actually, this should be done because hemoglobin plotted count and fibrinogen is necessary, because hypertensive emergency can lead to the development of DIC, may even lead to the DIC also. We should do the creatinine to find out there is any kidney involvement. eGFR should be done also to find out the kidney involvement. Serum electrolytes, LDH, haptoglobulin, this should be done. Urine albumin creatinine ratio, urine microscopy for red cells, leukocyte cast, and this should be carried out to diagnose the kidney involvement, as well as to find out also the cause of a patient with hypertensive crisis, that is hypertensive emergency. Because renal cause or renal involvement or a patient with acute glomerulonephritis or chronic glomerulonephritis or patient with the renal involvement can lead to the development of hypertensive emergency also. So we have to do the test, and pregnancy test in women with childbearing age, because eclampsia, preeclampsia may be associated with the pregnancy. And we have to also may have the troponin I to find out any coronary syndrome, CMMC, and also an NT-proBNP level. Because a patient with hypertensive emergency, this patient may have features of heart failure. So to diagnose, to confirm the heart failure, as well as to follow up the progression of the heart failure, we may need the NT-proBNP level. Chest X-ray may be needed to find out whether there is a fluid overload or not due to hypertensive emergency, and echocardiography may be needed and to see if there is a left ventricular hypertrophy, and to see the heart failure, as well as there may be ischemia, as well as to diagnose the even aortic dissection also. CT angiography of thorax or abdomen is suspected aortic disease to diagnose the aortic dissection. CT or MRI brain may be needed to see if there is any brain involvement. Renal ultrasound may be needed to find out if there is a renal artery stenosis. That may be a cause of the hypertensive emergency is suspected, or to see the renal impairment also. Urine drug screen there may be suspected methamphetamine or cocaine use. These may also lead to the development of hypertensive emergency, like cocaine use or methamphetamine abuse. So these are the actually workout investigations we have to carry out to find out the causes of the hypertensive emergency, as well as to see the impact of hypertensive emergency or defined organs of the body. That is to find out the severity of the target organ damage, and also to find out if there is any features of any target organ involvement due to hypertensive emergency. Actually, these are the investigation we have to look for actually. And with this, actually, today we can discuss another case. This is the case, a 40-year-old gentleman present with ischemic heart disease with blood pressure 150/100 mmHg. His ejection fraction is 40%. How this gentleman should be treated? And so these are the how we actually treat this patient with hypertension with ischemic heart disease with heart failure with reduced ejection fraction. So in a patient, what actually our evidence says, that is our study says, in adults with established ischemic heart disease and hypertension, a blood pressure target of less than 130/80 mmHg is recommended. That is in case of a patient with hypertension with ischemic heart disease. In that cases, the target blood pressure should be less than 130/80 mmHg, according to the American College of Cardiology guideline. An adult with established ischemic heart disease and hypertension, and should be treated with medications. In that cases, which medications will prefer? In that cases, we have to choose beta blocker at the first line antihypertensive drugs and ACE inhibitor ARB. There may be some compelling indication. If there is a previous MI or stable angina, in that cases, we have to choose beta blocker, ACE inhibitor or ARB. And we may need to add some other drugs if the blood pressure is not still controlled. In that cases, we may have to choose the second line antihypertensive as like dihydropyrid calcium channel blocker, thiazide diuretics, or MRA, mineralocorticoid receptor antagonist, as needed to control the further hypertension if hypertension is not controlled enough. And in patient with established ischemic heart disease, the angina, persistent uncontrolled hypertension, the addition of calcium channel blocker to beta blocker is recommended. That is, if a patient with ischemic heart disease with hypertension, if beta blocker is not enough to control the hypertension, so we may add another antihypertensive drug. In that cases, which group of drug we should choose? In that cases, we have to choose calcium channel blocker, and calcium channel blocker is the second line of antihypertensive drugs in a patient with hypertension with ischemic heart disease. So in adults with who have had MI or acute coronary syndrome, it is reasonable to continue beta blockers beyond 3 years as long-term therapy for hypertension. So if a patient has got ischemic heart disease in the form of mitral infarction or in acute coronary syndrome, so in that cases, a patient with hypertension, we have to choose beta blocker, the first line drugs. And the question is, how long we should continue this beta blocker? So we have to continue this beta blocker in that cases at least 3 years or ongoing, maybe lifelong. We have to continue the beta blocker as antihypertensive in a patient with hypertension with ischemic heart disease in the form of acute coronary syndrome or post-MI angina. And beta blockers and calcium blocker might be considered to control hypertension patient with coronary artery disease who had an MI more than 3 years ago and have angina. And in that cases, if a patient has got is getting beta blocker and still after 3 years, patient has still angina. So in that case, we have to continue the beta blocker, and along with beta blocker, calcium channel blocker may be added with beta blockers to control his ischemia, to control his angina beyond 3 years. So this is the flow chart, how we can manage a patient with hypertension with established ischemic heart disease. So if a patient present with hypertension with this established ischemic heart disease, in that case, we have to reduce the target BP as less than 130 over 80 millimeter mercury with beta blockers, ACE inhibitor, ORB. Then these are actually the first line antihypertensive drug. These are the class 1 indication actually. But if patient blood pressure is not controlled enough, the BP goal is not achieved with beta blocker and ACE inhibitor ORB. In that cases, which group of drugs we should consider next? In that case, still patient has got angina pectoris with uncontrolled blood pressure with beta blocker and calcium channel ACE inhibitor ORB. In that cases, we should add it dihydropyridine calcium channel blocker. It is a class 1 indication. If patient has got raised blood pressure despite the treatment of the with beta blocker and ACE inhibitor or ARB, but blood pressure is not controlled enough, but he has his angina is controlled. That is, the patient angina is relieved, but now this patient has got no angina. In that cases, we may add calcium channel blocker or thiazide diuretics or MRA mineralocorticoid as needed. Anyone or any more than 1 or 2 or 3 drugs may be added as the second line antihypertensive drugs in a patient with hypertension with ischemic heart disease. So this is the way actually we should manage a patient with hypertension and ischemic heart disease. And if a patient with hypertension and ischemic heart disease, we have to give beta blocker and ACE inhibitor ARB, the first line antihypertensive drug, to control the blood pressure as well as to control the angina. If the patient persisted, there is persistent angina, or there is a blood pressure is not controlled enough, that is the goal is not achieved, in that how we can manage the patient, just we have discussed here. So this is the way how we can manage a patient with hypertension with ischemic heart disease. And if a patient has got hypertension, ischemic heart disease, as well as patient has got heart failure, that is reduced ejection fraction, how the patient should be treated. In that cases, along with beta blocker, ACE inhibitor ARB is the first line choice. In that cases, non-dihydropyridine calcium channel blocker, that is amlodipine, nifedipine, cilnidipine. This drug we have to avoid it. We don't have to choose this group of drug as an angina control or as an antihypertensive drugs, because that may aggravate the heart failure or that may aggravate the angina also. So calcium antagonist, especially dihydropyridines, that is amlodipine and nifedipine, this should be avoided in a patient with heart failure actually. So this is the message we have to remember always. If there is a patient with hypertension, with ischemic heart disease, with heart failure, in that cases, dihydropyridine, that is calcium channel blocker, and this group of calcium channel blockers, that is amlodipine, nifedipine, should be always avoided. So what we learned, the two case scenario from today's lecture actually. So first lecture is about hypertensive emergency and urgency, that is hypertensive crisis. And the second is lecture, case scenario is about ischemic heart disease with hypertension with heart failure actually. So how we have to manage a patient with ischemic heart disease with hypertension with heart failure, reduced ejection fraction. So this is the way how actually we manage a patient. In the first case, hypertensive emergency, that is always a medical emergency, and we have to admit the patient to the hospital. And in case of hypertension with ischemic heart disease with heart failure ejection fraction, in that cases, how we have to manage this patient. This is important because there is a lot of patient in our hospital or in our settings, or even in the clinics or chambers. We have to across a lot of patients with these features like hypertension with heart failure with ischemic heart disease. So we have to treat the patient according to the evidence, what the evidence says, that is what is the guideline says. We have to treat the patient according to the guideline. And there may be a lot of antihypertensives in the market available. So we have to choose the right one for the right person, or we have to make the treatment individualized. That is, an individual patient should get according to his compelling indication, or according to the what he needs actually, or how he gets benefited maximum. So we have to choose those groups of drugs that can give his maximum benefit. So this is the way actually we should manage a patient with hypertension, and that is in a special situation how we can how we should manage the patient with hypertension. And I think we can end here today, and in the next class actually we have a more important discussion about the hypertension in pregnancy and some other important topics and a special situation also. So I think we can stop here today, and thank you for patient sharing, and thank you Axis Medical School for arranging such a nice class and give me opportunity to actually discuss about the hypertension and accordingly evidence-based and case-based. So thank you very much. Allah Hafiz.